Good evening. I am Dr. Kshitij. I'm a vitreoretina surgeon and ophthalmologist. I'm ophthalmology faculty in Medicoz Community, and we are here to discuss today 25 most important clinically based ophthalmology MCQs for NEET 2023 PG examination. So Medicoz Community is basically an online education platform. Uh, we have our website www.medicozcommunity.com, so you can log in there and see different kinds of things that we are offering. We are offering live interactive sessions, uh, question banks, then test series and notes from the faculties. We have early bird discount for early joining, that is 3,000 people who are joining on the first come first serve basis. So please avail these discounts, and there will be premier discounts and early bird discounts on the website. So let us move on to our today's session of ophthalmology. Before that, I want to tell you that whenever you are preparing for an exam like NEET, you have to find your why. Do not look for your motivation, find out your why. Then no excuses will come between you and your goals. I hope I am audible to all and visible on the live channel. You can text me on the message box in the live chat box if you have any of the queries and if you have any doubts regarding the PPT. So what I intend to tell you is your desire is most important driving force. Then no excuses will come in between your desire and everything. So let us start with the first question of today. So here is a 50-year-old male known case of retinal detachment and has come for follow-up post his cataract surgery. He is being dilated with tropicamide and phenylephrine drops post his vision assessment. What is the most useful clinical tool that will be used for fundus evaluation? So let me tell you that whenever any question comes in front of you, there are two things that you must see. Read the question very properly, see what you have been asked. If they have asked you what is right or what is wrong, what is true, what is false, so accordingly proceed. Secondly, if you know the question and the hints they are giving in the question, then fix the answer in your mind and go to the options then. If you don't know the answer, read the question, read the options, and again come back to the question. You will get the hint and then you will think better towards your answer. So here what we know about the patient is that he is a 50-year-old male. He is a known case of retinal detachment. He has come up for follow-up post his cataract surgery. He is being dilated with tropicamide and phenylephrine drops, that is T plus drops. What is the most useful clinical tool? So they want to know what is the clinical tool that you will be using to examine the retina of this patient. The options are direct ophthalmoscope, indirect ophthalmoscope, slit lamp with 90D lens, and optical coherence tomography. So here we know that indirect ophthalmoscope is the answer because it will be giving you the maximum view. All other options like direct ophthalmoscope, slit lamp, and OCT is not an examination tool, it is a confirmation tool, not a clinical tool. Okay, so what you should know in this question basically is indirect ophthalmoscope is a device which gives you a maximum area to be seen so that fundus examination could be better. There'll be less magnification as compared to direct ophthalmoscope. So there can be multiple questions asked based on these things to differentiate direct and indirect ophthalmoscope and its optics. While we get inverted image in indirect ophthalmoscope, we get erect image in the direct ophthalmoscope. So it is very important to rule out all the other three options. While we have been asked about the retinal detachment, All other lesions like peripheral retinal hole, lattice degeneration, and so on are also very important to be seen on indirect ophthalmoscopy only because of the field of view. OCT is not the first go to clinical modality, it is a confirmation device. Also, in the patients who are aged and who have cataract, in them also, the indirect ophthalmoscope is a better option to see because it will give a better field of view and better view in the cataract patients also. Moving on to the second question. All of the following are part of uvea except. This is a simple question based on anatomy of the eye. You know that middle coat of the eye is uvea. It is vascular. Okay. So uvea is the middle coat of the eye which is vascular and consists of three: choroid, pars, ciliary body, and iris. So the options that you have been given here are pars plana, pars plicata, and choroid. Out of this, pars plana and pars plicata are part of ciliary body, while choroid is part of uvea, and again ciliary body is part of uvea, while Schwalbe's line is not a part of uvea, it is a part of angle structure. So they have asked what are the parts of uvea except, and the answer is Schwalbe's line. Let us see pictographically and clear your concepts here. See, this is the iris, this is pars plicata, this is pars plana. So all these structures are in the middle coat of the eye. While in the angle structures of the eye, if you see, there is scleral spur, Slam's canal, trabecular meshwork. All these form the angle structures of eye and Schwalbe's line. Okay. The angle structures of the eye can be seen by gonioscope. You can use the gonioscope to visualize it. Moving on to third question. Here they have asked what is evisceration. Evisceration is option A, excision of entire eyeball, B, excision of inner contents of eyeball including the uveal tissue, C, photocoagulation of retina, or removal of orbital contents. Before answering this, let us see all these three terms. What is evisceration, what is enucleation, and what is exenteration? So evisceration means complete removal of all the intraocular contents through a keratectomy, that is a corneal incision and making out a corneal button and removing it. But in evisceration, what we do is we preserve the scleral shell, which is very important. So we preserve the scleral shell in evisceration, and all the extraocular appendages are also preserved in the enucleation. While in evisceration, and enucleation is the surgical procedure in which eyeball and the attached portion of the optic nerve is excised from the orbit. That is, the attached portion of optic nerve is severed from the orbit. And exenteration is the surgical removal of entire contents of orbit, eye socket, eyeball, fat muscles, and other adjacent structures of the eye. So can you tell me in the comment box which was the disease which was very popular in the COVID for which exenteration used to be carried out? Do tell me in the comment box. Coming back to our question, they have asked what is evisceration, and here the answer is definitely B, because excision of all the inner contents of eyeball including the uveal tissue, but scleral shell is preserved and the extraocular appendages are preserved. So what are this is another MCQ that you can get. What are the indications of evisceration and indications of enucleation? So you need to know the absolute indications first. For enucleation, malignancies like retinoblastoma and malignant melanoma are the indications here. While evisceration, the indications are panophthalmitis, exclusive choroidal hemorrhage, bleeding anterior staphyloma, and endophthalmitis when it is non-treatable or it is not coming back to normal levels. So enucleation has some relative indications like phthisis bulbi, endophthalmitis, painful blind eye, anterior staphyloma, congenital anophthalmia, and severe microphthalmia. I'll show you a beautiful figure so that you know what remains and what is gone in enucleation, evisceration, and exenteration. I hope you are answering in the chat box for what I have asked. When was exenteration done in COVID times, and what was the disease for which it was done. So enucleation, you remove the complete eyeball and sever the optic nerve. For evisceration, you keep the scleral shell intent and remove all the intraocular contents. While in exentration, you can see here, all the complete things are removed, including the extraocular appendages. Okay, so the question that I had asked was about the exentration, and exentration was done for which disease in the COVID times? Okay, you can answer till the class is over, then we'll discuss this question again. So coming to question number 4. Here the question is, patient age 65-year-old male with gradual diminution of vision has come since 6 months. He has gradual diminution of vision and has come to your OPD. He was operated for cataract surgery 15 years back, and he has 20/20 vision in both the eyes post cataract surgery. The cataract surgeon has ruled out post cataract opacity in any form and sent the patient for retinal evaluation. What is the correct sequence in which you will proceed? So basically they want to ask you that what is the sequence in which you examine the patient when he is operated for cataract surgery. So you always take the history first, then you go for best corrected vision and vision, then you go for slit lamp evaluation, then you go for direct and indirect ophthalmoscopy, and if needed, you go for modalities like OCT. So here the correct answer is B. So there is no confusion in this question. This was a very simple question. Whenever a patient enters your OPD, if you have been in the OPD, this is the correct sequence when you should examine the patient. Moving on to next question. A patient 35-year-old, known case of multiple sclerosis, comes to ophthalmology OPD for ocular evaluation. Evaluation was done for him and a consultant has evaluation which was done was visual acuity, slit lamp examination and dilated fundus evaluation. But a consultant scolded his resident for not mentioning color vision in this case and has emphasized the importance of color vision for the suspicion of optic neuropathy. What is true about color vision in the patient? So if you see the question, this is a 35-year-old patient. He is a known case of multiple sclerosis. So you should know that multiple sclerosis and optic neuritis have more than 50% of association, and always in such patients color vision should be taken. It should never be missed. So basically they are asking the question in which they are asking what is true about the color vision. So while taking color vision, distance at which patient should be made to sit at 6 meter, this is wrong because this is usually done when we are taking visual acuity at 6 meter. Dilated pupils are mandatory before checking color vision? No, because we see the color vision in undilated pupils only. Ishihara chart color vision can be used on OPD basis. Yes, this is the right answer. And color vision should be checked in dark room is the wrong answer. So color vision always should be checked in a well lit room. What you can see in the picture here is the Ishihara color vision chart. Again, I am asking you a question to give your comments in the comment box. The figure that you are seeing here, what is this? This is a test of color vision, different test of color vision. Please comment in the comment box to tell me what or which kind of test is this, or give me the name of this test. Okay, so few concepts about color vision. You should know that when you are checking color vision, the room should be adequately lit. Patient should not be dilated. You should be seeing the color vision undilated. Okay, and it can be checked with the Ishihara color vision chart. Do tell me in the comment box the name of this test. Moving on to next question, which is the sixth question for today. A patient 65 years old came with monoocular sudden severe. It is central retinal artery and central retinal vein occlusion. These are two most important causes of sudden and painless loss of vision. Along with that, CSR, central serous retinopathy. Along with that, optic neuritis, but optic neuritis sometimes can be painful also. Methyl alcohol amblyopia, yes, it is a sudden painless loss of vision. And vitreous hemorrhage is a, yes, sudden painless loss of vision cause. So now we are clear about what diseases we are thinking when we are given sudden severe painless loss of vision. On examination, the vision was perception of light, and there was RF light, and there was RAPD noted in the same eye. On fundus examination, there is box scarring of retinal vessels, and a cherry red spot is noted. So cherry red spot is a characteristic of CRAO. That means we've come to the answer. This is CRAO. CRAO is correct because it is a sudden loss of vision which is painless. Also you can see in this figure there is box scarring of retinal vessels seen, and you can see here cherry red spot can be seen in the center along with the pale retina because of the loss of blood supply, because of the damage of central retinal artery. To rule out the other options, CRVO cannot be the answer as vein occlusion fundus will appear very differently. Methanol poisoning cannot be the answer because there is no history suggestive of any methanol poisoning. Angle closure glaucoma is not the cause of sudden painless vision loss. It is a cause of painful vision loss. And moreover, patient does not have any complaints like headache or vomiting or conjunctival congestion to present like angle closure glaucoma. Answer me in the comment box, what is the management of CRAO? Because CRAO is a ophthalmic emergency, there are very emergency management treatments to be given, which is done in usually 6 to 8 hours of the features that patient will get because of CRAO. What things can we do? Do answer me in the comment box. So moving on to next question. A 30-year-old patient came with redness in the left eye since 2 days. He has discomfort and foreign body sensation with mild photophobia. He complains of seeing colored halos too. On examination, there was marked congestion, chemosis, and mucopurulent discharge. Treatment given was gatifloxacin antibiotic, topical, 1 drop 4 times per day. No steroids were used. What is the diagnosis? Now if we read the question again and if we see the options, all the options are conjunctivitis. So we know that we are dealing with a case of conjunctivitis. No need to use your more brain. So what are we given? We are given with the redness, discomfort and foreign body sensation, which is all there in all the conjunctivitis with mild photophobia. Apart from that, what we are given is colored halos. So there are some specific differential diagnosis of colored halos which you should definitely know because you will be asked a MCQ on this. Colored halos diagnosis are differential diagnosis are acute mucopurulent conjunctivitis, angle closure glaucoma, and incipient cataract. But since in this question we know that we are dealing with conjunctivitis, so we can proceed further with the symptoms given. Next symptom that we are given are marked congestion, chemosis, and mucopurulent discharge. And he has been treated with antibiotic gatifloxacin. That makes our diagnosis very clear that we are dealing here with bacterial conjunctivitis. So probably this is a mucopurulent bacterial conjunctivitis characterized by conjunctival hyperemia and mucopurulent discharge from the eye. To differentiate it from the other differential diagnosis, what we need to know is that in the bacterial conjunctivitis, symptoms will be more than signs. That is, marked congestion will be seen, purulent and mucopurulent discharge will be noted. Viral conjunctivitis, on the other hand, will have watery discharge. Even allergic conjunctivitis will have watery discharge. And in viral, the signs will be more than symptoms. In the allergic conjunctivitis, signs will be mild to moderate. Okay, but if you see the cytological features, you will be able to find some neutrophils or inclusion bodies in the herpes like diseases or pox when it is viral. So you need to know some basic features, clinical features of conjunctivitis like what we have discussed. Okay. Moving on to next question. Question number 8 for today. This question is, Kopes nodules are found in. Kopes nodules are found in So these usually are in uveitis, and the question is they are found in which structure of the eyeball. So both Kopes and Basaka's nodules are found in the iris, you know that, not on sclera, not on conjunctiva, or not on cornea. So here the answer is iris. What is very important to remember here is they can give you a picture based question also based on Kopes nodule or Basaka nodule. See, students, it is very important to remember the mnemonics, but if you remember mnemonics for both the things, Kopes nodules and Basaka nodules, you will eventually end up confusing both the things. So my advice is remember only one mnemonic, which is for Basaka nodules, which is B is equal to C. See, these are the Basaka nodules. You can see white lesions here. You can see in this picture, these are Basaka nodules. So these are at the collarate of iris. This is called as iris collarate. While the Kopes nodules, these are the Kopes nodules. Kopes nodules are seen always at the pupillary border of the iris. So remember Basaka at collarate, that is B is equal to C, and you will never forget this. Okay? Remember this mnemonic. So moving on to question number 9. Are we together? Everybody is following everything? You can give me your comments in the feedback in the live chat box. Okay? Moving on to question number 9. A patient 71-year-old came with complaint of sudden painless diminution vision in the right eye. We are dealing with sudden, again painless diminution of vision. On examination, the vision in right eye was counting fingers at 3 meters and RAPD was present. Anterior segment revealed NVI, that is neovascularization of iris, on slit lamp microscopy, and fundus examination revealed tomato splash appearance with blurred disc margins and multiple hemorrhages. What are we given here is tomato splash appearance with blurred disc margins and multiple hemorrhages. So what is the probable diagnosis? It is very important to remember that when we see the options, lot of our things get cleared. Now we know that in the options, all the things are given about vein occlusion. So we are dealing with vein occlusion or vascular occlusion. So this cannot be BRVO because it's branch retinal vein occlusion. We cannot see tomato splash appearance in the branch vein occlusion because only one branch will be affected. We are seeing tomato splash appearance with RAPD. That means we are dealing with ischemic CRVO and not non-ischemic CRVO because non-ischemic CRVO is a milder form than ischemic CRVO and RAPD will not be present in that. CRAO question we have already seen, so it is not central retinal artery occlusion. Okay. So this is how the tomato splash appearance looks. This is the figure. Tomato splash appearance because there are splinter hemorrhages and blurred disc margins. Also, RAPD is present in the ischemic CRVO and absent in non-ischemic CRVO. Also, remember that when there is branch retinal vein occlusion, there is macula involved with a part of vein, that is only branch of retinal vein occluded, and most common site for BRVO is superotemporal quadrant. Moving on to next question. A 30-year-old male, vision in right eye is 20/40. That means the patient has come with good vision, relatively okay vision. Complaints of unilateral blurring of vision. Okay, so there is unilateral blurring of vision along with metamorphopsia. What is metamorphopsia? Metamorphopsia is distortion of the vision. That means if a normal person sees a line straight, metamorphopsia, that means patient can see a person, the line wavy or slanting. Along with that, this patient has lot of work stress, history of sleep apnea. This is a type A personality with lot of work stress and history of sleep apnea. So upon putting up a weak convex lens, the vision in the eye improves. Further, the OCT is advised and the diagnosis is obtained. So what is the diagnosis here? So you know that patient complaining to you with vision 20/40 with metamorphopsia and type A personality with stress and improving with weak convex lens cannot be refractive error, cannot be cataract, cannot be glaucoma. The answer here is central serous retinopathy, that is CSR. See, central serous retinopathy presents like a serous detachment. You can see the fluid in the center of the retina and also in the corresponding OCT given. Okay, the same fluid, and there is a clear fluid present. So central serous retinopathy is an idiopathic disorder. It is characterized by only localized central serous retinal detachment in the sensory retina at the macula, secondary to the leakage from choriocapillaries through one or more hyperpermeable sites. So remember that this is secondary to the leakage from choriocapillaries. It is typically unilateral and it is a disease of young man with type A personality. The risk factors include psychological stress, steroid administration, pregnancy, sleep apnea syndrome, and Helicobacter pylori infection. So you must remember that a type A personality or a patient who is on steroid, if he presents to your OPD with such symptoms, you should think of CSR. There is unilateral blurring, metamorphopsia, correction by convex lens. Why is the correction by convex lens? That is plus lens. If you give a slight plus power to the patient, why does the correction occur? Because there is acquired hypermetropia. Why does the acquired hypermetropia occur? Because there is retinal elevation. Because of the neurosensory detachment which is localized, there occurs acquired hypermetropia because of the retinal elevation. Further, we confirm this diagnosis by doing OCT, and OCT shows that there is detachment of the sensory retina at the macula with clear subretinal fluid. And for the confirmation of metamorphopsia, you can use the Amsler grid chart. So the treatment for this condition is most cases will recover spontaneously and only observation will be required in the most of the cases. But in some cases which are chronic CSR or recurrent CSR, in those cases observation may not be sufficient. You may need to do fundus fluorescent angiography, that is FFA, and then you need to find the leak site by doing the FFA. When you find the leak site, you can give a focal laser at that leak site so that the leakage at that site will stop. Understood? Very clear? Can we move on to the next question? Okay. So a child aged 8 years has come to the OPD. His vision was 20/30 in both the eyes. Upon evaluation, he has complaints of difficulty in night vision. Well, the fundus has revealed golden metallic tapetal reflex at the macula. His paternal grandfather had history of same complaints. Full field ERG was done and that has revealed the diagnosis, that is confirmed the diagnosis. Which of the following is not true about the above mentioned disease? So which is the disease that we are talking about? This is a child. This is 8-year-old. He has come to your OPD with 20/30 vision. So fairly okay vision, but he has complaints in the night vision. Fundus has revealed golden metallic tapetal reflex at the macula. And this is a heritable disease. That means paternal grandfather was having the history of same complaints. Furthermore, they have done a full field ERG to confirm their diagnosis. That means we are dealing here with retinitis pigmentosa. Okay. What is the triad of retinitis pigmentosa? It is waxy disc pallor, bony spicules, and arterial attenuation. Can you see in this figure that this is pale disc? So waxy disc pallor along with, see, these are the lesions you can see. These are called as bony spicules. Along with that, what you can see these arteries are very thinned out. You can see the arteries, the vessels, all the vessels and arteries are thinned out, very thinned out arteries. Okay. So coming back to the question, what they have given in the options is which of the following is not true. We need to find what is not true about the above mentioned disease, that is retinitis pigmentosa. The first option is triad of waxy disc pallor, bony spicules, and arterial attenuation is classic. Yes, this is true. A typical disease may be associated with syndromes such as Usher syndrome, Refsum's disease, Kiran-Sari syndrome, and Bardet-Biddle-Moon syndrome. Yes, this is also true. Association with myopia is present. Yes, RP has association with myopia. D is no need of follow-up and it's a resolving disease. This is wrong. We need to follow up retinitis pigmentosa all cases, and it is not a resolving disease. It cannot resolve. So option D is not true because retinitis pigmentosa needs follow-up. Follow-up is for what? If the patient gets cataract, then you can treat him because surgically cataract can be removed, and retinitis pigmentosa patient can develop posterior subcapsular cataract. In those cases, you need to remove the cataract, like do the cataract surgery, and even the RP patients can develop cystoid macular edema. In those cases, you can give them dorzolamide drops for the treatment of CME. Currently, retinitis pigmentosa has no specific treatment, but some research work is going on where gene therapy and retinal prosthesis like Argus prosthesis and all is developed, and that shows promise for future. While the conservative therapy that you can really give to the patient right now includes avoidance of smoking, wearing sunglasses, giving vitamin A supplementation of 15,000 units per day, and keeping the patient on follow-up. So remember, you cannot not keep the patient on follow-up. You have to keep him on follow-up. Okay. Moving on to next question. Everybody is clear with all the previous things. If you have any doubts, please post in the text box. The operation of which of the following instruments is based on first Purkinje-Sampson image? Is it indirect ophthalmoscope? Is it retinoscope? Is it C, slit lamp? Is it keratometer? Or is it the cross cylinder? So Purkinje-Sampson image. Let us know about all the four Purkinje-Sampson image. See, this is the first Purkinje-Sampson image. This is coming from the anterior surface of the cornea, right? The second Purkinje-Sampson image is coming from the posterior surface of the cornea, while the third Purkinje-Sampson image is coming from the anterior surface of the lens, and the fourth is coming from the posterior surface of the lens. So coming back to the question again, which device do you think deals with the first Purkinje image that is coming from the anterior surface of the cornea? The answer here is keratometer. Why? Because keratometer is a device which measures the astigmatism of the central anterior surface of the cornea. So it is based on the first Purkinje-Sampson image. Keratometer is based on the principle that anterior surface of the cornea acts as a convex lens, so that the size of virtual image formed by the anterior corneal surface is proportionate to the corneal radius of curvature. Okay. So all other options will be ruled out as they don't deal with the anterior corneal surface. Clear? Moving on to the 13th question of today. A 39-year-old man with diagnosis of severe aplastic anemia presented with hemorrhage as shown in the figure. Symptoms were severe lethargy, palpitation, gum bleeding for 2 weeks, along with planeless blurring of vision for 2 days. Poor vision was not associated with floaters, flashes of light, or any field defects. There was no history of heavy lifting, straining, or prolonged coughing. There is no history of trauma or exposure to noxious chemicals or irradiation. Given on the fundus photo, what is the diagnosis? Let us see what we are given in the question. Remember, whenever the question is big, you are given a lot of hints and you can definitely conclude and come to an answer. See here the diagnosis of severe aplastic anemia already there for the patient. There is severe lethargy with palpitation and gum bleeding. Okay. And the figure is given, which is showing a hemorrhage, which is like boat shaped. And the options here are retinal detachment, amyloidosis, subhyaloid hemorrhage, and asteroid hyalosis. So this is definitely not retinal detachment because fundus has no features of that. This is not amyloidosis. This is subhyaloid hemorrhage. And this is also not asteroid hyalosis. We will discuss all the other three options also, but let us see first about the subhyaloid hemorrhage. So the subhyaloid hemorrhage is a condition where bleeding is located anterior to the internal limiting membrane. Typically, it is boat shaped in nature. What are the other causes of subhyaloid hemorrhage? Valsalva retinopathy, Tierson syndrome, shaken baby syndrome. In age-related macular degeneration, it can occur, yes, sometimes secondarily or late. Blood disorders, diabetic retinopathy, bleeding secondary to RAM, that is retinal microaneurysm, hypertension, and also secondary to the trauma. So the question was very clear. It was about the hemorrhage, subhyaloid hemorrhage. It was boat shaped. What about the other options? Amyloidosis, we know it is a systemic condition, or it can also be a localized condition in which there is extracellular deposition of fibrillary protein. Here the vitreous involvement occurs and vitreous opacities may be seen, which are unilateral or bilateral. So understand this. This is amyloidosis in which vitreous involvement will be seen. Retinal detachment, the fundus in the given question doesn't look like that, and it is altogether a different topic to discuss. Asteroid hyalosis is a common degenerative process in which calcium pyrophosphate particles collect within the vitreous gel. Tiny round white yellow white opacities. You can see in this figure. This is a figure in which the media has become blurred because of asteroid hyalosis. Okay, this is there in the vitreous gel and it moves with the vitreous asteroid hyalosis during the eye movement. Mostly only one eye is affected and it rarely causes visual problems. Okay, asteroid hyalosis looks like this. So we're clear about the question, answer, and the other options that were given. Okay. अब आ रहा है स्क्रीन पे अगला सवाल, क्वेश्चन नंबर 14. So it's a 2-year-old child. This is slightly a different question. It's a difficult question. So read the question very properly. So 2-year-old child presented with poor light fixation on the dilated fundus examination. There was homogeneous dome-shaped white lesion with vitreous seeding found. Okay, vitreous seeding. Patient was then seen by retina specialist and white reflex was noted. The fundus findings were confirmed. Examination under anesthesia, which is also called as EUA, was carried out. USG B scan showed tumor with calcification. Okay, so B scan has been done. Examination under anesthesia has been done. Which of the following is not the mode of transmission of the disease? Okay, so first of all, which disease are we dealing with here? What we know about in the question is there is white reflex. Most important hint is white reflex. There is homogeneous dome-shaped white lesion, poor light fixation, and vitreous seeding. That means in a 2-year-old child, all these features are usually of retinoblastoma. So we are dealing here with retinoblastoma. USGB scan has also showed calcification. What they are asking here is which of the following is not the mode of transmission of this disease? See, retinoblastoma is hereditary. It is a germline mutation. So this is right. This is not the answer. Non-heritable, yes, it is non-heritable. It is RB1 gene mutation. Yes, Knudsen's hypothesis tells us that it is a defect in RB1 gene. So what is the answer here? Answer is autosomal recessive. It is not transmitted, autosomal recessive. So some things that we must see about retinoblastoma. Let us discuss some things about retinoblastoma. It is most common primary intraocular malignancy of childhood. The genetic transmission, as we have already seen in the options, is heritable. It is germline, RB1 gene, autosomal dominant. Sometimes non-heritable somatic, but these are mostly solitary cases. The presentation is bilateral tumors in the first year and unilateral tumors in the second year of life. What is most important sign or important symptom or important presenting feature that clinches the diagnosis is leukocoria or white pupillary reflex. It should never be missed. Strabismus, that is squint in the eye, is the second most common presenting feature of retinoblastoma. If patient presents late, then he will present as painful red eye with secondary glaucoma with poor vision. There can be inflammation or pseudo-inflammation. There can be orbital inflammation seen. If a patient seen in the late case, you will also see the metastatic disease involving the regional lymph nodes and the brain. Most of the retinoblastomas are undifferentiated, but varying degrees of differentiation can be characterized by structures like rosettes. So these rosettes are of three types: flexor Winsteiner, Homer Wright rosettes, and florets. Let us see in the figure diagrammatically. See, these are flexor Winsteiner rosettes. You can be given a picture-based MCQ directly asking what is this. So it is seen in retinoblastoma, remember this. Nextly, what investigations will you do for retinoblastoma patients? You will first see the reflex. Is there a red reflex? Using a direct ophthalmoscope, you can see that or not. If it's a white reflex, then definitely you must refer it to the retina surgeon. You can do a examination under anesthesia. Okay, evaluation under anesthesia. You can do a USG B scan, which will show you the exophytic or endophytic kind of tumor. You can do CT scan for seeing the calcification inside the tumor. Systemic assessment can be done and genetic studies can be done. The treatment of retinoblastoma depends on the stage of retinoblastoma, which is altogether a very different topic and a vast topic, which we will see later when we discuss retinoblastoma in detail. So can we move to the next question, which is our 15th question. Which of the following is not a cycloplegic drug? And your options given here are phenylephrine, atropine, humatropine, and tropicamide. You can also be asked what are the constituent of the most commonly used dilating drop, which is T+. So T+ drop is the commonly used dilating drop, which consists of phenylephrine and tropicamide. So I need your answers in the comment box. What is the concentration of phenylephrine and tropicamide used for the T+ drop? Coming back to our question, what has been asked here? Which of the following is not a cycloplegic drug? That means 3 drugs given in the option are cycloplegic and 1 drug is not cycloplegic. Okay, so let's see. Atropine, humatropine, and tropicamide. All these 3 are mydriatic drugs. Okay. Phenylephrine also is a mydriatic drug. So drugs which dilate pupil are called as mydriatics. Everybody agrees? Definitely. Drugs which paralyze the skin is not a cycloplegic. It is only a mydriatic. So in our only a mydriatic. So in our questions, if we see the options, which is not a cycloplegic drug is, answer is phenylephrine here. So the other class of drugs, sympathomimetic, which are adrenaline, cocaine, epinephrine and pyridine, these are mydriatic drugs only. These are not cycloplegic. These are only mydriatic. So you should know what are only mydriatic drugs and what are cycloplegic drugs and what are both mydriatic and cycloplegic drugs, because you could be asked. So I'd asked you one question about T+. What is the concentration in the T+? It is 0.8% and 2%. So 5% of tropicamide and 0.8% of phenylephrine is used in the T plus drop, which is most commonly used drop in the OPD basis. Okay, चले अगले क्वेश्चन की ओर. अगला क्वेश्चन आपके स्क्रीन पर अभी ये रहा. क्वेश्चन नंबर 16. This is about trachoma. In trachoma, which of the following is false? A. It is commonly caused by serotypes like chlamydial serotypes D to L. B. Follicles are present, generally smaller than 0.5 mm. C. Herbert's pits are present at the superior limbus. D. Heel trachoma generally has no activity. Give your answers in the comment box. Let us first discuss trachoma and then come back to the answer again. So this is the WHO grading of the trachoma. See, you can see there are a lot of big follicles that you can see here. See, all the whitish color follicles you can see. So in the WHO staging, there is inflammatory stage of trachoma, that is trachomatous inflammation follicular, trachomatous inflammation intense, then happens the trachomatous scarring, and the sequelae of that is trachomatous trichiasis and later on causing corneal opacity. So these are very big follicles, not the small follicles. They have pronounced inflammatory thickening of tarsal conjunctiva, okay, and deep tarsal vessels can be involved, appears very red, very rough, very thickened. There are numerous follicles which then go to the scarring stage. In the scarring stage, the scars can be easily seen as white lines, okay, bands or sheets. Then you can see the stage of trichiasis, where one eyelash rubs on the eyeball, and evidence of recent removal of intense eyelashes can also be graded as trichiasis. And because of this, the sequelae happens, that is corneal opacity, and the patient's vision becomes blurred because of corneal opacity. See, these are some of the very good pictures that you can see. You can see the whitish follicles here, whitish big follicles. This is Art's line, conjunctival scarring. These are Herbert's pits. Herbert's pits in the superior limbal part. This is Panus formation. This is trichiasis, as we saw. And this is the sequelae of trachoma again. This is cicatricial entropion, that is lid is involved. So coming back to question first. What was our question? In trachoma, what is false? So it is caused by serotypes D to L. Yes, this is true. Follicles are present generally small? No. So this is the answer. Follicles are larger. Herbert pits are present at the superior limbus. This is true. Heel trachoma generally has no activity. Yes, this is also true. So our answer is B. Okay. Coming back to discussing some more things about trachoma. See, what is important in trachoma is there are some MCQs which are very frequently asked about Herbert follicles, which later become Herbert pits. And you should also differentiate trachoma from vernal keratoconjunctivitis. So what are Herbert follicles? These are superior limbal follicles. These are on the superior limbus, which resolve and they leave some pits here. These are called as Herbert's pits at the limbocorneal junction. Okay, and these are covered by epithelium. So Herbert pits are found in the trachoma. While in the vernal keratoconjunctivitis, what you see is similar thing but very different, because it is seen as discrete white spots at the apices. They are called as Horner-Trantas spots. This is another MCQ. So remember this. Horner-Trantas spots are seen in the vernal keratoconjunctivitis, and they are distinctly seen as white, discrete white spots. Basically, these are made up of degenerated epithelial cells and eosinophils. Understood? You can see very distinctly in this figure also. Okay, so differentiate both these things and remember in your mind. You will never forget now. चलते हैं अगले क्वेश्चन की ओर. Question 17 here. So which of the following statements about herpes zoster ophthalmicus is false? Option A, headache often precedes the rash. Option B, it is caused by RNA containing virus. Option C, glaucoma should be excluded. Option D, corneal sensation may be reduced. Excuse me for 1 minute. So we are dealing here with herpes zoster ophthalmicus. Let us see first about the herpes zoster disease and then we'll come back to the answer. We know that herpes virus is DNA containing virus, and hence even without knowing about the herpes disease much, if you see the answers, you know that it cannot be RNA. So your answer is B here. Which of the following statements about herpes zoster is false, they have asked. So it is not RNA, it is DNA. Okay. The pathognomic feature of herpes infection is dendritic pattern of the epithelial defect of cornea. Okay. So when the cornea is involved, you see the dendritic pattern. It may cause stromal infiltration and keratouveitis with secondary glaucoma and corneal opacity. See, when the corneal spectrum of herpes disease is noted, it is mentioned that they have herpes can cause epithelial keratitis, can cause stromal keratitis without ulceration, stromal keratitis with ulceration, and also it can involve the endothelium, so it can cause endothelial keratitis. Can you tell me in the comment box which of these 4 categories will you not use steroid? In which of these 4 categories is the steroid contraindicated? Tell me in the comment box. So there are some specific nomenclatures given for herpes: dendritic keratitis, geographic keratitis, interstitial keratitis, necrotizing keratitis, and disciform keratitis as respect to the involvement. Okay. So I've asked you one question. In which of the following 4 categories will you not, the steroid is contraindicated? Okay. So did not get answer for this. It is epithelial keratitis. You don't use steroids for epithelial keratitis. So this is another MCQ which they will ask you. So the treatment for epithelial keratitis will be antiviral drugs, topical or oral, along with the debridement if you need to do it. While in the stromal keratitis without ulceration, you can use topical steroids and antiviral oral prophylaxis. With the ulceration, if patient presents, then use oral antiviral in therapeutic doses and use oral steroids, topical steroids. In the endothelial keratitis, you can use topical steroids along with oral antivirals in the therapeutic doses. So I hope the stages and the categories of herpes ophthalmicus are clear to you. Moving on to next question, which is question number 18. Which of the following is true regarding thyroid ophthalmopathy? Okay, this is based on thyroid disease, thyroid eye disease. So which of the following is true regarding thyroid ophthalmopathy? A, it is the commonest cause of unilateral or bilateral proptosis in adults. B, it causes pulsating exophthalmos. C, in patients with ocular Graves' disease, the ophthalmopathy may proceed, follow, or coincide. D, therapeutic control of hyperthyroidism improves the exophthalmos. So what is the answer? Answer is A plus B plus C. Okay, that means commonest cause of unilateral or bilateral proptosis in adults is thyroid ophthalmopathy. Yes, it causes pulsating exophthalmos. Yes, it is seen in patients with ocular Graves' disease. With ophthalmopathy may proceed while presentation, or it may follow, or it may coincide. While the D option is definitely not true, because therapeutic control of hyperthyroidism does not improve exophthalmos. Okay. So thyroid ophthalmopathy presents as different signs of lid retraction that we can see. infiltrative ophthalmopathy, proptosis, restrictive myopathy, when the extraocular muscles can also be involved in thyroid. So the sequence of involvement of extraocular muscle in thyroid eye disease is given by a mnemonic. This mnemonic is I am slow. The involvement of extraocular muscles is inferior rectus first, then the medial rectus, then the superior rectus, and then the lateral rectus and levator muscle. And then last come the oblique muscles. Okay, so remember this mnemonic I am slow. If they ask you the question on involvement of extraocular muscles in thyroid eye disease, the involvement is by the inferior rectus gets involved first. So pulsating exophthalmos, one more thing that we need to discuss is with bruit and without bruit. So pulsating exophthalmos with bruit is seen in carotid cavernous fistula, while in thyroid it is simple pulsating exophthalmos. Okay. Also exophthalmos is also seen in orbital roof fractures. Coming to the thyroid disease features again, do remember that eyelid retraction, soft tissue involvement, proptosis, optic neuropathy, and strabismus. And sequelae of thyroid disease is exposure keratopathy. So all these are features of thyroid eye disease. And some signs that we need to discuss in the thyroid eye disease. What can you see in this figure? There is lid retraction seen in the primary gaze. You can see there is lid lag, delayed descent of upper lid in the down gaze, and starring appearance of the eyes of the patient. So there are some important signs in thyroid disease which you need to know. That is von Graff's sign, which is lid lag in the down gaze. It's called as von Graff's sign. Lid retraction in the primary gaze is called as Darrell-Impels sign. Gifford sign is difficulty in elevating the upper lid, everting the upper lid. Griffith sign is lid lag on upgaze. Mobius sign is unable to converge the eyes. And Stelvach sign is infrequent and incomplete blinking. When we deal with thyroid disease in detail, we will always see these signs in more detail. Okay. Now we can move on to next question. Question number 19. Which of the following drugs increase the rate of lacrimal secretion? The option A is atropine, option B antihistamines, option C pilocarpine, option D phenylephrine. What is the answer here? Atropine A, antihistamines B, pilocarpine C, diphenhydramine D. Answer is only pilocarpine. So answer is C. Okay. Why? Because pilocarpine is a cholinergic drug, and cholinergic drug increases the rate of lacrimal secretion. We have been asked that which of the following drugs increase the rate of lacrimal secretion. So cholinergic drug like pilocarpine will increase the rate of lacrimal secretion, while parasympatholytic drugs like atropine will decrease the rate of lacrimal secretion. Also antihistaminics, they have anticholinergic action, so they will decrease the rate of lacrimal secretion. Only thing that increases the rate of lacrimal secretion is pilocarpine. Okay, this is very simple and easy to remember and understand also. So we can move on to next question, I think. This question is about Horner's syndrome. A slightly tricky question in which if you know the details of concept of Horner's syndrome and oculosympathetic pathway, then this is not at all difficult to answer. But very important is to listen to this question when I am giving the explanation. So what have they asked in the Horner's syndrome? 2% cocaine dilates normal pupil and not Horner's pupil. 4% cocaine dilates normal pupil and not Horner's pupil. 1% hydroxyamphetamine will dilate a pupil with preganglionic lesion but not post-Horner's pupil. 2% hydroxyamphetamine will dilate a pupil with preganglionic lesion but not a postganglionic Horner's pupil. Okay, let us go to Horner's syndrome first. Let us discuss it and come back to options and let's then discuss the answer. So basically, what is Horner's syndrome? Horner's syndrome is oculosympathetic palsy. Okay, you can remember it with a mnemonic, MAP. What is MAP? As you can see in this figure, ptosis, meiosis, anhydrosis. Then what does one more A stand for? Ptosis, meiosis. So this is ptosis, meiosis, anhydrosis and anisocoria. What is anisocoria? Both pupils will be different in size. So ptosis, meiosis, that is constricting pupil, drooping of eyelid, anhydrosis, and along with that anisocoria will be seen. So remember this mnemonic MAP for Horner's syndrome. So Horner's syndrome is caused by partial or a total interpretation of sympathetic chain between the hypothalamus and eye. This is a pathway which is 3-neuron pathway, right? In that, the pathway goes from brainstem, then it goes to spinal cord, then it goes to cervical sympathetic ganglia, then it goes to carotid artery, adventitia of carotid artery, then it goes to 7th and 5th cranial nerves. Okay, cranial nerves. So in this pathway, there are 3 neurons involved, 1, 2 and 3. Now in Horner's syndrome, basically oculosympathetic pathway is affected, we know that. Now when this pathway is blocked, how will you know if it is blocked between first order, second order or third order? You cannot know if it is blocked between 1 or 2. You can know if it is blocked between 1 or 2 or 3, that is preganglionic and postganglionic. Okay, how will you know this? Let us see. If you use cocaine, what is cocaine? It is a indirect sympathomimetic. So sympathomimetic drugs have 2 categories, indirect and direct. So indirect is cocaine and hydroxyamphetamine, which we have been given in the question. So if you use cocaine, the role of cocaine is to block the reuptake of neurotransmitter, and the role of hydroxyamphetamine is stimulation of norepinephrine. Now when you know that the pathway is blocked, and if you use the cocaine, it is going to give the reuptake, which will not give any benefit. So it will not dilate the pupil in Horner's. While if you use the hydroxyamphetamine, it usually stimulates norepinephrine. So even if the pathway is blocked in the pre-sympathetic level, at that level it will stimulate norepinephrine and it can dilate the pupil. But if the pathway is blocked in the post-synaptic level, then hydroxyamphetamine will not act. Okay, so coming back to our question, the answer here is B and C. That means option C finally. Okay, this is the answer. Cocaine dilates normal pupil. Yes, this is true, but not the Horner's pupil. Why? Because cocaine will not dilate because the pathway is already blocked. Hydroxyamphetamine will dilate a pupil with preganglionic lesion but not a post-Horner's pupil. So we can also say that cocaine is used to test that if a pupil is Horner's pupil or not, to confirm it, because the pupil will not dilate with it. While hydroxyamphetamine will be used to confirm if the lesion is preganglionic or postganglionic Horner's. Okay, this is very important to know. Okay, what is the another sympathomimetic drug we have seen? This cocaine and hydroxyamphetamine. These are two indirect acting sympathomimetic. Which is the direct acting sympathomimetic drug? Please comment in the comment box. And that is also used for a test in Horner's syndrome. The name of that drug you can comment in the comment box. So we can, I think, move to the next question. Snow banking is pathognomic feature of A. Tuberculosis, B. Leprosy, Pars planatis, or VKH syndrome. Let us first see what is snow banking. Snow banking is due to organized exudates over the pars plana. Okay, there are exudates which are settling in the pars plana. See in this figure. This is called as banking. Okay, while snowballing, these are suspended cells and debris in the vitreous cavity. See, these are some cells here. These are suspended, okay, in the vitreous cavity. It's a pathognomic sign of pars planatis. So snow banking is organized exudates which are there in the vitreous cavity, and these once present will always remain. This will not go, and it is a pathognomic sign. These are basically seen in intermediate uveitis or pars planatis. Okay, there can also be seen in the cases like Lyme disease, sarcoidosis, and multiple sclerosis, and very rarely in tubercular intermediate uveitis. But these are very pathognomic of pars planatis. So your answer here is pars planatis. Hope everybody is clear with what is snowballing, what is snow banking. Okay, these are in this figure you can see some more features seen in uveitis like chorioretinal scarring, vitreous cells. Again, there are snowball, snowbank, and vitreous haze. Okay, moving on to next question. Third nerve palsy involves all of the following except. Okay, so what do we know about third nerve palsy? Firstly, what do we know about nerve supply of the extraocular muscles? We know that L, R, 6 and S, O, 4, right? That means LR is lateral rectus, which is supplied by 6th nerve, superior oblique is supplied by 4th nerve, and all other extraocular muscles are supplied by 3rd nerve. So, about the third nerve palsy, all of the following is there except what? So, when we know that just a minute. LR6 and SO4 are intact and only third nerve is affected. That means it will cause down and out eye, third nerve palsy. It causes down and out because abduction is caused by lateral rectus muscle. So abduction will be there. So third nerve palsy involves ptosis, adduction and elevation palsy. Okay, but it will not cause abduction palsy because abduction is caused by lateral rectus which is supplied by sixth nerve. Okay, so answer is abduction palsy. Total third nerve palsy presents as ptosis, down and out eye. Okay, the eye is down and out. There is abduction due to unopposed action of lateral rectus. There is intorsion, there is fixed and dilated pupil, and there is weakness of accommodation. So I hope everyone is clear with the third nerve palsy. Now we can move on to next question. The next question is characteristic retinal hemorrhage shown in the figure is Roth spot. Okay. So now they have given the information that the retinal hemorrhage seen in the figure is Roth spot. Fundus. This fundus was seen in the ICU patient and his blood counts were significantly deranged. His hemoglobin was significantly low. Patient has been chronically ill and receiving treatment since long time. Which of the following disease is most commonly associated with this sign? Okay. Is my screen visible? Yeah. I think there was some technical glitch in 22nd question where the third nerve palsy question was there. So I hope everybody has understood that eyeball remains down and out in third nerve palsy and lateral rectus is always acting. It is not compromised in third nerve palsy. So there is lateral rectus palsy and hence abduction palsy is not the answer. Everything else is involved in third nerve. Okay. Now moving on to 23rd question. The characteristic retinal hemorrhage shown in the figure is Roth spot. The fundus was seen in the ICU patient and his blood counts were significantly deranged. His hemoglobin was significantly low. Patient has been chronically ill, receiving treatment since long time. Which of the following disease is most commonly associated with this sign? So what we have been given is this is a figure based question in which we can see all the hemorrhages. But how are these hemorrhages? These hemorrhages have a central whitish area of clearing, right? And what is this hemorrhage called? This is a special type of hemorrhage called as Roth spot, specific hemorrhage. So these Roth spots are seen in typically ICU patients like where hemoglobin is very low in these patients. So what are the differential diagnosis when you see a Roth spot? You can either see them in anemic patients, you can see in anoxia, carbon monoxide poisoning, diabetes, endocarditis patients. You can also see them sometimes in HIV patients or where hemoglobin is very low due to intracranial hemorrhage or preeclampsia or systemic hypertension patients and leukemia patients. So coming back to the question, what have we been asked is which of the following disease is most commonly associated with this sign? The most commonly associated disease is leukemia. Okay, so this is sign is the Roth spot, hemorrhage is seen, and this kind of fundus finding is seen in that. Along with other disorders like blood dyscrasia, anemia, leukemia, these are the most common disorders seen. Why are white centers seen in the hemorrhage? Is because the whitish element is thought to be composed of coagulated fibrin in most of these cases. So the fibrin that coagulates comes in the center of the hemorrhage, and that is why this hemorrhages are seen with white centers. Okay. Can we proceed to the next question now? I hope all the technicalities are fine and everybody is following everything. Coming to the last two questions. Urgil-Robertson pupil includes which of the following features except, read the question very well, except what? Okay. Urgil-Robertson pupil. Let us know something about Urgil-Robertson pupil first before discussing the answer. Urgil-Robertson pupils are smaller pupils. They do not constrict when exposed to the normal light. They only constrict when focused on a near object. Okay. So Urgil-Robertson pupil do not constrict when exposed to normal light. They constrict to when they are focused at a near object. That means what is this condition called? This is called as light near dissociation. So I'll give you a mnemonic to remember Urgell-Robertson pupil, and the mnemonic also is Urgell-Robertson pupil, that is ARP. What is the full form in the mnemonic? It is accommodation, reflex, present. Okay, this is very simple to remember. Accommodation, reflex, present. That means pupil only dilates at the time of accommodation or near object. So coming back to the question, Urgell-Robertson pupil include which of the following features except light near dissociation? Yes, it is a feature. Bilateral asymmetrical pupillary involvement? Yes, it is a feature. Large pupil? No, because we have seen the pupil is myotic and small. Irregular pupil? Yes, it is a feature. So answer was C. And some more features that you should know about Urgell-Robertson pupil is it has light near dissociation. It has asymmetrical pupillary involvement. Vision in the affected eye can be normal. It is myotic pupil. It has irregular pupil, and it has poor pupillary dilatation after installation of mydriatic. What are the other kinds of pupil who have light near dissociation? These are addictonous pupil. Pupils can be seen in diabetic mellitus patients, and Perinaud's syndrome is also associated with light near dissociation. So remember these things. Okay. अब आएगा आखिरी सवाल आपकी स्क्रीन पे, ये रहा क्वेश्चन नंबर 25. Interpret the following image. So this is an image based question, and state which lobe of the brain is involved. So what have we been given here? This is a perimetry charting showing quadrantic sectoral defect. Okay, we have been given pattern deviation also corresponding to the same. That means patient has quadrantic superior defect. So before finding the answer of this question, let us first be well versed with visual pathway. You should be very well versed with visual pathway. You should know that this is your eyeball and this is your retina. The temporal retina corresponds to the nasal one, and the nasal retina corresponds to the temporal visual field. Okay, know this first. Then regarding the visual pathway, when we go down, this is the temporal retina. This is right eye, this is left eye. We are seeing the optic tract right, and optic chiasm is in the center. Now when there is defect near to the eye, that means closer to the eye, first defect, this is total loss of vision in the eye, because this defect is at point 1 where it is damaging both of these. So complete damage will be there, and it will cause a total loss of vision in this eye. While in the second kind of defect, where it is at the optic chiasma, there will be a temporal hemianopia. Understood? This and this is damaged. That means here the temporal, the nasal retina causing the temporal half to be damaged, and here the nasal causing the temporal half to be damaged, causing the bitemporal hemianopia. While in the optic tract, which is the lesion number 3, it will cause contralateral hemianopia. Coming to the next lesion, which is at 6 level, geniculocalcarine tract, will cause a homonymous hemianopia, just like optic tract, which was at 3. Okay. If the lesion is in the visual cortex or the primary visual cortex, or it's called as calcarine fissure, there are 3 kinds of lesions here: inferior, at the inferior bank, at the superior bank, and at the both banks. So at the inferior bank, it will cause homonymous quadrantanopia. Inferior bank will cause superior lesion, superior bank will cause inferior lesion, and both banks will cause contralateral lesion with macular sparing. So what I mean to say is, if the lesion is in the primary visual cortex, it will be a macular sparing this thing with homonymous hemianopia. And coming back to our question, what was our question is, the appearance which we were seen in the perimetry was this one: superior left homonymous quadrantanopia, which is pie in the sky disorder. See, this is seen at the 4th blockage. Here, this is going to the temporal lobe, right? And this is going to the parietal lobe. So the 5th one here is the parietal lobe, which will cause pie in the floor defect, parietal lobe. And what we are seeing, the fourth one, it'll go in the temporal lobe and it will cause pie in the sky defect. So this characteristically, this perimetry chart shows pie in the sky defect, and hence the answer should be inferior fiber of optic radiation of temporal lobe, while pi in the floor will be superior fiber of optic radiation of parietal lobe. Understood? Pi in the floor will be superior fiber of optic radiation of parietal lobe, while what we are asked in this question is pi in the sky, and it is inferior fiber of optic radiation of temporal lobe. Understood? So be well versed with your visual pathway. Any questions? I am ready to take in the comment box. And thank you so much for your kind attention, and hope you had a very nice learning experience. You can always connect with me at any time and ask me questions. So I can see a lot of answers in the comment box. Nice to see that all of you were active in the session. Okay, thank you again. We'll meet at the next